Alright, now one of the things after tri-flap reconstruction is usually the plastic surgeons will advise that the patient must keep the leg in this position, bent. Because you must remember this muscle was taken to create a new breast, so it's very tight. Now if you keep the leg stretched, it will be very uncomfortable and you might actually cause dehiscence or break of the wound. So you don't want that. So usually at least for the first 2 days, you want the patient to be in this position. So they will put pillows or for the beds that can be adjusted, then they will be adjusted. So the patient will be in this position, usually for 2 days. Okay? Now, this is another reconstruction. This is one of my patients, whereby she underwent the LD flap reconstruction. She presented with, she's a single teacher, presented with a lump. It's measuring about 6 centimeters at the upper inner part of her breast. She didn't want to lose her breast, right? Which is understandable. She's only in the early 40s. So with much persuasion, finally she agreed to have neoadjuvant chemo. She was very reluctant, but I asked her to go back, think about it, come back in 1 or 2 weeks and think about it. So finally, thank God, she agreed to my advice and she had neoadjuvant chemotherapy. And the 6 centimeter lump shrunk to 4 centimeters. Okay? Now she didn't want to lose the breast, she didn't want to have an implant. Okay, so how do you settle that problem? So I gave her the option that I could try, where we removed 1/3 of her breast. Okay, so I removed 1/3 of the upper part of the breast, up there, along with the lymph nodes. You can see the scar. Now we took, because her skin was very close to the cancer, I couldn't save the skin. Okay, so I had to take the skin away. So when you take the skin away, you got a hole there. What we're going to do? So we had to take the skin from the back, along with the muscle, and swing it to the front. Okay, so that now you can see, if you look, the shape of the breast is similar. Okay, it's similar, but you can see a patch of skin, unfortunately, which is from the back. But if you observe her two sides, her breasts, they're both quite similar. And she's very pleased with that. Okay? Now, this is another lady. Now, her cancer was just behind the nipple, areola complex. Okay, but the rest of the skin was fine. So we kept the rest of the skin, and we removed the nipple areola complex, and we reconstructed again, just like the previous lady. Alright, so if you look, the shape is quite the same. Unfortunately, you don't have the nipple areola complex. Now, I did suggest to her on a reconstruction of a new nipple areola complex, but she says, don't bother. And I'm happy now, at least I can put on my clothing without worrying about prostheses falling out of my bras and looking very different when I undress. I'm quite happy to be the way I am. So yeah, you respect their wishes, but that's how she looks. Okay.
Yeah.
Now, so traditional versus delayed. The first patient was a delayed. Traditional mastectomy, where you take the skin away and you delay the reconstruction. This is compared to the other patient on the right, where you save the skin envelope, right? And you do immediate reconstruction, so it's quite different. So if the first lady on the left were to wear a low-cut dress, okay, a low-cut dress, nightgown or something, you can see the scar peeping up. If she wears a low-cut dress like this, you can see the scar. If that lady were to wear a low-cut dress, not really, unless you want the whole nipple areola to pop up, then you don't really need to wear the dress anyway. Okay? So it's like different there. Okay, now when the patient undergoes a mastectomy, a skin sparing mastectomy with an LD, yeah, the muscle at the back, Now the muscle at the back is much smaller than the tummy muscle. So the muscle at the back, more often than not, when you remove the entire breast, you have to put in an implant. Okay? So we've got two types of implants. The one on the left is a fixed size implant. It means that's how it is, you can't change it. And the one on the other side is an expandable implant. You have a port. You have a port here, which goes under the skin of the patient. Post-operatively, usually 2 weeks onwards, every week the patient comes and you can pump this up with saline gradually, so this will inflate. And you pump it up till it reaches the size of the opposite untouched breast. Okay, you do it gradually. So once you reach the size you want, then you stop. Okay, now the port, once you reach the size, you can take it out. There are some patients who say the port's not doing anything, you can leave it be, then fine, leave it be. Okay? There are some patients who like this idea of inflation, and they kind of joke with me in clinic. They say, if I'm going for a party, can you pump it up for me a bit? Well, that wasn't the original idea, but okay. Okay, now another important thing I'd like to touch on is the post-operative bra. It is a very comfortable bra, which I found recently in the market. I also don't have a share in this company. Now, it is made of cotton, right? And it's made of cotton, and it's front fastening. Okay? So for those who've had surgery, especially axillary dissection, when they have to do this, it's a bit uncomfortable. So this really helps. Okay? Now, for those after reconstruction, we normally advise them to wear this 24 hours for 6 weeks. So you need at least 2 pairs of bra, especially when it's a bit hot and sweaty. Okay? Now, the reason why it's advisable to wear this bra is it supports the breast. Right? Where you've had the reconstruction, if you didn't wear the bra, it will be hanging down. Because of the gravity, it can pull on the scar line. So when it pulls on the scar line, it can be uncomfortable, number one. Number two, indirectly, it can make the healing of the scar thicker. So you get thicker scars, which is not what most women want. So advisable to wear this. I normally tell them, okay, and at least 2 pairs. Now, I'll just touch a bit. Remember that I mentioned when you talk about surgery, you need to do surgery on the breast, you need to do surgery on the lymph nodes. Yes? Okay, lymph nodes is important. Lymph nodes is distributed all over the body. In particular, we will concentrate on the axilla, where you have 15 to 30 lymph nodes per axilla. Now, why you need lymph nodes? This is God's creation. The main function of lymph nodes is to trap and destroy any foreign material, our enemies basically, bacteria, virus, cancer. That's the main idea why we have lymph nodes not only in our armpits, we have it all over our scalp, face, groin, all over the place. So that is their main function. They are basically the soldiers. They patrol the body, and they try and keep all these enemies under control. Okay? The problem is, right, sometimes the lymph nodes get defeated. Okay? Now, if you leave the cancer long enough and they duplicate in numerous numbers, they overcome your lymph nodes. So now your normal body mechanism, your lymph nodes have been taken over by the enemy. So the enemy, once it takes over the lymph nodes, it sets up camps. Now your original lymph nodes have become headquarters of the enemy. Okay? So you can't leave them behind. They need to be sorted. That's the main reason why we need to sort out the lymph nodes. If you just remove the breast alone, that's not enough. You haven't sorted the problem adequately. Okay? Now, lymph node surgery. Now, there are two types: the classical lymph node surgery, axillary dissection, where we remove larger numbers of lymph nodes. It can vary from 10 to 35 lymph nodes, right? Now, because you disrupt the lymph nodes and the lymphatic channels considerably, you have about 10 to 30% risk of lymphedema post-surgery. Lymphedema is swelling, and this risk is lifelong. Okay? Now, the other newer option is probably some of you have heard is sentinel lymph node biopsy, where we remove usually less than 6 lymph nodes, and because the disruption of lymphatic channels and networks is less, you can see that the risk of lymphedema, although not 0, but it shrinks down from 30 to 3%. So you cut it down by 10%, cut it down 10 times, which is very good, okay? So, but not all patients are eligible for this, and not all centers have this option, okay? I'm quite happy to say that UKM Medical Center was the first center to offer this procedure in Malaysia, okay? Now, the word sentinel actually means soldier. You are the one guarding the front line. Okay, so you have a group of soldiers, and the one at the front line is the sentinel that we're referring to here. Okay, so the theory is, if you are the soldier guarding the front line, okay, and if you do receive any enemies, you will be the first to receive the enemy. That's the idea. So when we do the surgery, sentinel lymph node surgery, we're trying to look for these frontline soldiers and take them and sample them and see whether they have any cancer or not in them. Okay? But how do we identify these sentinel lymph nodes? So we have two methods, which is using technetium, which is radioisotope material, and also using a dye, a blue dye called patent blue dye. So two methods or two mechanisms whereby we try and identify which are the possible involved lymph nodes. You must understand here that we have 15 to 30 lymph nodes, yes? Now, if you do not sample them properly, you can be taking the wrong lymph nodes. Alright? And if you take the wrong lymph nodes, that means you have the wrong information. So if you sample the wrong lymph nodes and you think that there's no cancer, but you have